Hey everybody, hope everyone is doing just fine. And I hope everyone is delighted at the numerous good news that I sent you out in my Blackboard announcement. And I guess first principally, you all did pretty good. And that's a really good thing because perhaps you'll recall in the beginning of the semester I told you that if your first exam grades were the lowest of the remaining exam grades, that I will reduce the weight of that first exam significantly. And under the new grading criterion, each exam is worth 33%, of course, because I've decided to drop the term paper requirement. But what's still going to hold up is the fact that relatively poor performance on the first exam, the contribution of that poor performing first exam will drop significantly. So I think many of you will find that helpful, especially in light of the fact that many of you did so much better in the second exam. So I'm really delighted. And of course, if you haven't read the announcement already, I'll mention it here again. I've made an adjustment in the remaining course requirements, and namely, I'm dropping two of the chapters, the one on industrial organizational psychology and the one on personality. And between now and the end of the semester, we will be focusing on psychological disorders and therapy. So today's lecture is going to be on, just one more aside, and I know I mentioned it in my announcement. That is, the last exam is going to be administered and published precisely the same way exam two was administered, and it seemed to have worked very well for everybody. That is, it's going to be put on Blackboard. You're going to have 75 minutes to take the exam, and it's 33 multiple choice questions, and it's only going to be on the chapter on abnormality, psychological disorders, and therapy. That's two chapters. Okay, so keep that in mind. That is all we're covering for the rest of the semester. The last official day of the semester, by the way, is May 15th. So it's right around the corner. But I have every reason to believe everyone in this class is going to do just fine. So, what are psychological disorders? And in order to adequately answer that question, we're going to cover piece by piece various aspects of it. One is, of course, a definition of a psychological disorder. Everybody wants one. And what is meant by cultural expectations, harmful dysfunction, and the like. So let's define psychological disorders a little more formally. Psychopathology is the study of psychological disorders, including their symptoms, etiology, which means causes, and treatment. Now, of course, that begs the question, what is a psychological disorder? It is a condition characterized by abnormal thoughts, feelings, and behaviors. Behaviors, thoughts, and inner experiences that are atypical, dysfunctional, or dangerous are signs of a psychological disorder. However, there is no single definition of a psychological abnormality or normality. Just because something is atypical does not mean it is disordered. For example, and this is adequately illustrated in your OpenStax textbook, chapter 15, red hair is considered unusual, but it is not abnormal. So what is meant by cultural expectations? Sometimes normality and abnormality seems to be dictated by violating cultural expectations, but that's not enough by itself to identify a psychological disorder. See, social norms vary between cultures, and what is considered appropriate in one culture may be viewed differently in another. For example, hallucinations is a violation of cultural expectations in Western societies. People who report hallucinations are likely to be labeled with a psychological disorder. However, in some cultures, certain types of hallucinations are highly valued, which leads us to, as we work towards the definition of psychological disorders and psychopathology, it leads us to understanding other very, very basic concepts as it relates to its definition. And one is harmful dysfunction. Harmful dysfunction proposes as a more influential concept in which we define psychological disorder as something that causes harm to an individual. Dysfunction occurs when internal mechanisms, for example, cognition, perception, and learning, breaks down and cannot perform its normal function. You'll see the implications of that when we talk about psychoses and some of the most severe of psychological disorders, the schizophrenias. For a dysfunction to be classified as a disorder, it must also be harmful, as I just mentioned. And the harm leads to negative consequences for the individual or for others, as judged by the standards of an individual's culture. To get a good grasp of what we mean by psychological disorders, psychopathology, we turn to the American Psychological Association, the APA, that offers up a pretty good definition of what a psychological disorder is. More formally, it is a condition that consists of the following, and therapists, psychiatrists, and clinical psychologists always look to these conditions as part of the definition as to what is a disorder and what is not. First, there should be significant disturbances in thoughts, feelings, and behaviors. And of course, nested within that are cultural norms. So those disturbances in thoughts, feelings, and behaviors would operate outside of cultural norms. A second distinction is that the disturbances reflect some kind of biological, psychological, or developmental dysfunction. And the disturbances lead to significant distress or disability in one's life. For example, difficulty performing appropriate and expected roles. But interestingly, despite the many existing definitions, there is no universal agreement on where the boundary between disordered and not disordered is. Let us now turn our attention to diagnosing and classifying psychological disorder. And for that, we refer to what is frequently called the Bible of the mental health community. And what I'm alluding to is the Diagnostic and Statistical Manual of Mental Disorders, also described as DSM. The DSM, of which the latest revision, by the way, is 5. It started out first as DSM and then DSM-1. We use Roman numerals, by the way, for those big classifications, and then we use R to describe revisions to the major classifications. Basically, the DSM is involved in diagnosing, appropriately identifying and labeling a set of defined symptoms. And the DSM, which is published by the American Psychiatric Association, but all mental health professionals use it, was first published in 1952, and as I just alluded to, has since undergone numerous revisions. The first 2 editions, by the way, listed homosexuality as a disorder, but was removed in 1973. The DSM-5 is the classification system, as I've already mentioned, used by most mental health professionals. And it categorizes and describes each disorder. It has built into it diagnostic features, which is basically the overview of the disorder, and we're going to cover some of those. A diagnostic criterion, which refers to very specific symptoms that are required for diagnosis, its prevalence, that is, the percentage of the population thought to be afflicted, and risk factors. It also provides information about comorbidity. Comorbidity, which you may have heard of in the context of COVID-19, people who present with COVID-19 and say also have high blood pressure or diabetes, which are significant risk factors for the mortality level of COVID-19, are comorbid conditions. That is, the occurrence of more than one disorder at the same time. As described in your OpenStax textbook, let us now turn our attention to perspectives on psychological disorders, of which I'm going to describe three of them: the supernatural perspective, the biological one, and the diathesis stress model. With regards to supernatural perspectives, well, for centuries, psychological disorders were viewed from a supernatural perspective. What do we mean by a supernatural perspective? Disorders attributed to a force beyond scientific understanding. For example, practitioners of black magic. The notion that people are possessed by spirits, and the application of witchcraft. Frequently, treatments included things like torture, beatings, and exorcism. Between the 11th and 17th centuries, there was an epidemic in Western Europe. And that was characterized by large groups of people suddenly beginning to dance with wild abandon. Some would dance for days or weeks, screaming of terrible visions. And although the cause is unknown, the behavior was attributed by many to supernatural forces. More contemporary is the notion that we can view psychological disorders as linked to biological phenomena. Things like genetic factors, chemical imbalances, and brain abnormalities is supported by evidence that most psychological disorders have a strong genetic component, which of course doesn't mean that if you are identified as having a genetic component, say, contributing to schizophrenia, it doesn't mean you definitely will develop schizophrenia. And if you recall the previous chapter on development, genes always operate in interactive fashion. It's never completely one way or the other. All genetic expression has an environmental expressive component to it. A person's risk of developing schizophrenia increases if a relative has schizophrenia. The closer the genetic relationship, the higher the risk. If you look at figure 15.8 in your OpenStax college textbook, you will see a really nice illustration of the heritability estimates for schizophrenia. Also consider the psychosocial perspective, which emphasizes the importance of learning, stress, faulty and self-defeating thinking patterns, and environmental factors. We'll get into self-defeating thinking patterns when we explore the application of cognitive behavioral therapy in the section on therapy. But the psychosocial perspective views the cause of psychological disorders as a combination of both biological and psychosocial factors. The other perspective that I alluded to earlier was the diathesis stress model, which integrates biological and psychosocial factors to predict the likelihood of a disorder. Namely, that diathesis plus stress yields to a development of a disorder. People with underlying predisposition for a disorder, that's what we mean by diathesis, underlying predisposition for a disorder, are more likely than others to develop a disorder when faced with adverse environmental or psychological events. A diathesis can be a biological or a psychological vulnerability. Let's now turn our attention to some of the major DSM-5 classifications of psychological disorders. But I want to give you a little bit of a heads up. As you read through the chapter and I describe some of these disorders, including their etiology and their symptoms and so forth, there's a tendency to develop a belief that maybe you are suffering from some of these disorders. You may have heard me mention in the class in the past of something called medical student syndrome. It's an interesting phenomena that occurs rather reliably among medical students, first year and second year medical students. When you're exposed to all the pathological conditions that they are required to learn about, they start to develop belief that they may be suffering from some of these disorders. So very, very severe headaches become tumors or some kind of very severe organic syndrome. Well, you kind of like get the idea. I want to caution you about developing any of these erroneous conceptions. Well, this is not to say that any one of us might in fact be suffering from these disorders. What we have to be careful about is drawing the conclusion that we definitely are just based on the material that's presented to us. The only way that you can establish whether you are in fact suffering from a psychological disorder is to seek out the help of a mental health professional. That is truly the only way. But more on that when we get to the topic on therapy. So with regard to anxiety disorders, what we're going to do is we're going to discuss specific phobias, acquisition of phobias through learning, social anxiety disorder, panic disorder, and generalized anxiety disorder. But in order to really understand what anxiety disorders are, we have to come to a good understanding of what is meant by anxiety. And for that, we compare it to fear, which everyone is very familiar with. What is fear? Fear is an instantaneous reaction to an imminent threat. You know what that's like. You step out into the street, car just suddenly appears out of nowhere, and you have that overwhelming fear reaction, which is characterized by physiological activation, the fight or flight response, which you perhaps recall from the chapter on biological psychology. So fear is clearly biologically driven by the mechanisms that you learned about in biological psychology, and everyone has experienced it. Anxiety, which is closely related to fear, is a sense of apprehension, avoidance, and cautiousness regarding a potential threat, danger, or other negative content. This is not to say that feelings of anxiety is not real. We've all experienced it. It is very, very real. But as such, what it does is it motivates us to take action and avoid certain things, meaning that anxiety has a very, very adaptive component to it. Now, in most normal circumstances, the level and the duration of an anxiety usually matches the magnitude of the potential threat. However, some people experience anxiety that is excessive, persistent, and out of proportion with the actual threat. So, anxiety disorders. They are characterized by excessive and persistent fear and anxiety, and by related disturbances in behavior. Generally speaking, anxiety affects approximately 25 to 30% of the US population during their lifetime. It seems to occur with slightly more frequency among women than men. And it is the most frequently occurring class of mental disorders. Let's talk about specific phobia. That involves excessive, distressing, and persistent fear or anxiety about a specific object or a situation. People may realize their fear and anxiety is irrational, but may still go to great lengths to avoid the stimulus. With regard to its prevalence, It affects about 12.5% of the US population at some point in their lifetime. Now, some common specific phobias include acrophobia, which is a fear of heights, aerophobia, which is a fear of flying, arachnophobia, fear of spiders, and claustrophobia, fear of enclosed spaces. I mention these not just incidentally, but these are most commonly reported specific phobias. And if you're interested in entertaining yourselves about these conditions in a more film-like narrative, I think Hollywood has done quite a number of movies touching on each of these. I know that there are a couple of movies about arachnophobia. In fact, there's a movie, I believe it was done by Steven Spielberg. It was called Arachnophobia. But let's talk about another common type of phobia. It's called agoraphobia, and it is listed as a separate anxiety disorder. Agoraphobia is characterized by intense fear, anxiety, and avoidance of situations in which it might be difficult to escape or receive help if one experiences a panic attack. I know Greek agor means open places, but rather, technically speaking, what we mean by open spaces is not the fact that it's the openness that elicits the fear, but it is the fear of it is the intense fear that's experienced when they're out, and the avoidance it is there to try and minimize the feelings of the anxiety, and in particular a panic attack, which I will describe in a few moments. Some situations that agoraphobics avoid are like public transportation, crowds, or being outside the home alone. How do we explain many of these phobias? Well, some of the models you already introduced to, and you may recall that I have mentioned them in the context of the topic that we were covering, and I'm referring to learning. Recall classical conditioning. Child is bitten by a dog. That's the unconditioned stimulus. The dog becomes associated with biting, the conditioned stimulus, and the child experiences fear around dogs. Conditioned fears develop more readily to fear relevant stimuli, that is, images of snakes and spiders, than to fear irrelevant stimuli, images of flowers. Another mechanism is vicarious learning. Child observes cousin react with fear around spiders. Child later expresses the same fears even though spiders have never presented any danger to him. Vicarious learning also explains why some people develop intense fears of flying. If the classical conditioning were to be strictly applied to fear of flying, then it would beg the requirement that the person actually get on the plane and experience something via the unconditioned response pathway. But just by hearing about air disasters, plane crashes, and so forth may be sufficient via the mechanisms of vicarious learning to create the very, very intense fear of flying. And perhaps you recall that I had mentioned in the class an old friend of mine who had fear of flying, and he was able to conceal it from everyone until his changing job responsibility required that he fly, and that he couldn't. And the treatment for that, one of the most effective treatment for that, which I'm sure you recall that I've mentioned in the class, is something called systematic desensitization. But we'll talk about that in more detail when we get to the chapter on therapy. Another mechanism of it is through verbal transmission of information. If a child is continuously told that snakes are dangerous, the child starts to fear snakes. Let us now talk about another anxiety disorder, and it's called social anxiety disorder. This is characterized by extreme and persistent fear or anxiety and avoidance of social situations in which the person could potentially be evaluated negatively by others, leading to serious impairments in life. Generally, it seems to be associated with lower educational attainment, lower earning, poor work performance, and unemployment. Social anxiety disorder is experienced by about 12% of Americans during their lifetime. And it has a comorbidity. Remember that term? Comorbidity, the concurrence of another kind of condition. It has a high rate of comorbidity with alcohol use disorder. More on that later. Individuals may self-medicate to reduce anxiety in social situations. And there are a number of risk factors that are associated with social anxiety disorder. Fears of social situations possibly develop through conditioning. And 92% of sample of adults with social anxiety disorder reported a history of severe teasing in childhood. Another risk factor seems to be behavioral inhibition, a consistent tendency to show fear and restraint when presented with unfamiliar people or situations. Let us now talk about another anxiety disorder, which I'm sure many of you are probably familiar with, and that is panic disorder. Panic disorder are recurrent and unexpected panic attacks, along with at least 1 month of persistent concern about additional panic attacks. It consists of worry over the consequences of the attacks or self-defeating changes in behavior relating to the attacks. It has a comorbidity situation, that is namely other anxiety disorders or major depressive disorders, which we will cover a little bit later. A panic attack is a period of extreme fear or discomfort that develops abruptly and reaches a peak within 10 minutes. It can be expected in response to an external trigger or unexpected. Panic attacks alone are not a disorder. Some of the physical manifestations of a panic attack are shown. People may also experience sweating, trembling, feelings of faintness, or a fear of losing control, among other symptoms. I refer you to figures 15.9 in your OpenStax textbook, which characterizes and illustrates some of these symptoms. Feeling dizzy, unsteady or lighthearted, shortness of breath, chest pain, palpitations and or accelerated heart rate, nausea or abdominal distress. Research seems to suggest that there is a strong genetic component to panic disorders, including a 43% of heritability. And there are numerous theories, some biological theories, to explain that. Let me elaborate. In a neurobiological theory, the locus ceruleus, which is in the brainstem, is possibly involved. Major sources of norepinephrine, you recall that was a neurotransmitter that triggers the fight or flight response. This was covered in chapter in biological psychology. And its activation is associated with anxiety and fear and produces panic-like symptoms in non-human primates. Another theory is conditioning theories. Panic attacks are classical conditioned responses to subtle body sensations resembling those normally occurring when one is anxious or frightened. A third are cognitive theories. These are individuals with panic disorders are prone to interpret ordinary body sensations catastrophically, setting the state for panic attacks. In some patients, reducing catastrophic conditions, these are thoughts, about sensations has proven to be as effective as medication in reducing panic attacks. And we'll get to that on the chapter on therapy, right? This concept is embodied in cognitive behavioral therapy. Let us now turn our attention to another anxiety disorder. And by the way, I obviously cannot cover all of them. I strongly encourage you, by the way, to take additional courses in on the topic of psychological disorders or psychopathology. Everything that I'm talking to you now is expanded out over an entire semester. And maybe some of you might feel that maybe actually becoming a professional, a mental health professional, would be something of interest. And if that is the case, and if my interaction with you has helped in that endeavor, I would pat myself on the back and say, job well done. Over the years of teaching, I've had quite a number of students reach out to me later on and said that I was influential in setting kind of like a career path for them in mental health, including things from psychiatry to mental health counseling to clinical psychology and so forth. And we'll talk about those distinctions when we get to therapy. But let's now talk about generalized anxiety disorder. Generalized anxiety disorder, sometimes referred to as GAS, G-A-S, is a relatively continuous state of excessive, uncontrollable, and pointless worry and apprehension about everything. Its diagnostic criterion, the diffuse, fuzzy worrying and apprehension, is not part of another disorder. The symptoms occur more days than not for at least 6 months. We call this persistence. The symptoms are accompanied by any 3 of the following symptoms. Now, please, as I describe this, don't self-diagnose. Restlessness, difficulty concentrating, being easily fatigued, muscle tension, irritability, and sleep difficulties. Again, please, many of us experience these things, and in some cases on a more regular basis than we would like to admit. It doesn't necessarily mean you are suffering from this particular condition, especially in the context of our COVID crisis. Many of us may be experiencing these things that are a function of those particular type of stressors, and not because we're already predisposed to have or develop generalized anxiety disorder. In order to ascertain that, you must seek out the help of a mental health professional. The prevalence of generalized anxiety disorder, it affects about 5.7% of the population during their lifetime. Now, while that may seem like a very, very small number, consider that what we mean by, say, 6%, we're talking about if I were to randomly select 100 people, 6 of those are going to be found to be suffering from it. So I think a 6% frequency in the U.S. population is relatively high. And interestingly, females are twice as likely as males to experience the disorder. And there's a comorbidity. Again, remember that term. If there's one word that you're going to really love to remember from this point forward, is comorbidity, the concurrence of other conditions along with the one that you're principally talking about. It is comorbid with mood disorders and other anxiety disorders, which means that someone with generalized anxiety disorder might also have phobias and also might be suffering from depression, but we'll talk about depression a little bit later. Let's now turn our attention to another class of disorders called obsessive compulsive and related disorders. And what I'm going to explain to you in a few moments, obsessive compulsive disorders, sometimes described as OD, body dysmorphic disorder, hoarding disorder, and then the causes of OCD. Obsessive compulsive disorder, or OCD, involves thoughts and urges that are intrusive and unwanted. We call these obsessions. Or the need to engage in repetitive behavior or mental acts. We call these compulsions. So obsessions refer to the thoughts and urges, intrusive and unwanted, because you can't control them. And this is typically accompanied with a need, an uncontrollable need to engage in repetitive behaviors or mental acts, compulsions. What are obsessions? They are persistent, unintentional, and unwanted thoughts and urges that are highly intrusive, unpleasant, and distressing. you already know what obsessive thoughts are. Do you ever have sort of like a particular song that you like, and the melody just keeps popping into your head, and you're thinking about something else, and then suddenly, intrusively, that melody appears. Except you may sometimes find that a little annoying to experience that, but it's not too persistent. And although it has some level of unintentionality, you can still bring it under control. We consider obsessions to be somewhat pathological is if the degree of persistence and the unintentionality and the unwanted thoughts and urges are so highly intrusive, they're also very, very unpleasant, and they are distressing. What are some common obsessions? One is concerns about germs and contamination, which in the present COVID climate would be very, very interesting, and how the COVID-19 situation seems to exacerbate many of these symptoms of people with OCD. And in particular, those who have concerns about germs and contaminations. Another common obsession is doubts. Another one, order and symmetry. And another one, aggressive or lustful urges, all of which are covered in your chapter. Compulsions, on the other hand, which is the behavioral element of it, characterizes repetitive and ritualistic acts, typically carried out primarily as a means to minimize the distress that obsessions trigger, or to reduce the likelihood of a fear event. It is not performed out of pleasure, and the person usually knows these obsessions and compulsions are irrational, but suppressing them is extremely difficult. And it is experienced by approximately 2.3% of the US population in their lifetime. To see some really nice illustrations of obsessive compulsive disorder, I refer you to figure 15.11 in the OpenStax College textbook. There, in one illustration, repetitive hand washing is described. Another one is checking that the door is locked. I've experienced that myself many, many times, and perhaps you've experienced this as well. You leave your home, and you not sure whether you remember that you locked the door or not. And I suspect that living in a very heavily populated area in New York City in particular, and I grew up in New York City, you never left your house without being sure that your door was locked. But and there have been many, many times where I thought I locked the door, left, and said, well, now I'm not so sure, and I've gone back to check to see if I've locked the door, and I have done that with my car. So perhaps you want to say, Professor J is very, very OCD about locking his house door, or his car door for that matter. I've done that many, many times as well. Although now all I have to do is pull out my keys and press a little button, and I hear beep, 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 and that's telling me that the car is locked and stuff. But what we're talking about here is not just the tendency to do that, but whether or not it becomes a very common obsession and compulsion. Other common compulsions in this are cleaning, ordering, and counting. But again, just persisting in these things do not mean that you are suffering from obsessive compulsive disorder. The OpenStax chapter also describes body dysmorphic disorder, and we are now almost 40 minutes into the presentation, so I'm going to leave it to you to look at that particular section as I try and move along with the material. I want to try and keep this entire presentation to just under an hour. Okay, so I'm going to ask you to go in and review the material on body dysmorphic disorder, and I am only doing this to expedite matters. But I suppose hoarding disorder is worth mentioning even here, because I believe that there's a cable show, or maybe more than one cable show, that describes individuals and portrays individuals with a hoarding disorder. In this disorder, the condition is characterized by great difficulty in discarding possessions, regardless of how valueless or useless they are. Perhaps you've seen this on the cable show. Person, you go walk to a person's home, and there are just literally stacks and stacks and stacks of newspapers, and obviously old newspapers and clippings. They're pretty valueless or useless, right? But they are unable to let go of those items. Now, if you've got old stuff that you can't get rid of, again, that doesn't mean that you're suffering from a hoarding disorder. You wouldn't believe how many glasses I have, and I have actually about 7 or 8 of them. And wow, maybe that surprises you. Part of it is that my refractive my vision refraction changes as I get a little bit older, and I just don't discard the old glasses. But I still have them tucked away somewhere. Somehow I just can't seem to get rid of them, so I've accumulated them, right? And you probably notice also that these are relatively new glasses as well, but not because of the refractive problem. Well, but. But somehow the people with severe hoarding disorder are unable to let go of items. They think the items might be useful at a later time. And there also may be some sentimental value to those particular items. The excessive clutter prevents the individual using necessary living spaces, such as the kitchen or the bed. And they are diagnosed as long as the hoarding is not a symptom of another disorder. For causes of obsessive compulsive disorders, we believe that the neuroscience has a lot to add in that. With regard to brain anatomy, we have identified what we have come to call as the OCD circuit. There are several interconnected regions that influence perceived emotional value of stimuli and selection of behavior and cognitive responses. In one particular part, the orbitofrontal cortex, the anterior cingulate cortex, and the prefrontal cortex. I'm going to refer you to figure 15.13. Take a look at that. It nicely illustrates in 15.13 the OCD circuit that the professionals have identified. Let us now turn our attention to another classification of disorders, disorders of mood. In the DSM, the Diagnostic and Statistic Manual, we call these mood disorders. And what I'm going to cover are major depressive disorders, including the subtypes of depression, bipolar disorder, and then I will discuss the biological basis of these mood disorders and the cognitive theories of depression and suicide. Now, generally, mood disorders are characterized by massive disruptions in mood and emotions that can cause a distorted outlook on life and impair ability to function. We call the one broad category is called depressive disorders, and the condition is called depression. And depression is characterized as intense and persistent sadness, which is the main feature. Another one are bipolar and related disorders. Mania, which is extreme elation and agitation, is the main feature of it. And individuals with bipolar disorder may frequently experience manic episodes, which is a distinct period of abnormally and persistently elevated, expansive or irritable mood, and abnormally and persistent increased activity or energy lasting at least 1 week. Now, according to the DSM, there is a diagnostic criterion which must be met in order to meet the diagnosis of major depressive disorder. And one is depressed moods lasting most of the day and nearly every day. Another is a loss of interest and pleasure in usual activities. At least 5 symptoms persist over a 2-week period. And these symptoms cause significant distress or impair normal functioning and are not caused by substance or medical condition. Major depressive disorder is episodic, meaning the symptoms are usually present at their full magnitude for a certain period of time and then gradually diminish. The symptoms of depression, and again, I want you to be very mindful of the tendency to self-diagnose. So let's be careful about that, especially in the current climate. There's reasons to to feel distressed or depressed. Some of the symptoms are weight loss or weight gain, accompanied or not accompanied by an increase or decrease in appetite, difficulty falling asleep or too much sleep, psychomotor agitation or psychomotor retardation, fatigue, loss of energy, feeling of worthlessness or guilt, difficulty concentrating, indecisiveness, and suicidal ideation, which is thoughts of death, thinking about planning suicide, and suicide attempts. Now, again, I can't overemphasize the fact that we have to be careful in taking, some of these symptoms and applying it to ourselves. Many of us experience these symptoms. It really does require diagnosis in order for you to come to that conclusion. So keep that in mind. Let's touch on the prevalence of major depressive disorders. It affects around 6.6% of the U.S. population and 16.9% of the U.S. population in their lifetime. And there too, depression is more common among women than men. But I've seen some interesting research that describes why its incidence seems to be a little higher in women than in men. And it may be that men are less likely to report symptoms of depression than women. And it does have a comorbidity with anxiety disorders and substance abuse disorders. And some of the risk factors for it, and we need to keep that in mind in the current COVID climate, because many of these conditions many of these risk factors are present: unemployment, right? Low income, living in urban areas, and being separated, divorced, or widowed, right? All of these are risk factors to major depressive disorder. Let's turn our attention to bipolar disorders. Bipolar disorders involve mood states that fluctuate between depression and mania. Symptoms of mania: excessive talkative, excessively irritable, exhibit flight of ideas, would talk loudly and rapidly, abruptly switching from one topic to another, easily distracted, exhibit grandiosity, inflated but unjustified self-esteem and self-confidence, show little need for sleep, take on several tasks at once, engage in reckless behavior. The prevalence of bipolar disorders is typically an onset before the age of 25 and affects 1 out of 100 people. That's 1%. 36% of these individuals attempt suicide. And the comorbidity situation with bipolar disorders are anxiety disorders and substance abuse disorder. Usually regarded as one of the most severe of all the psychological disorders, and this is not to say that depression is not a very, very severe disorder. It is. But one of the more incapacitating psychological disorders are those that fall under the DSM category of the schizophrenias or the psychotic disorders. Schizophrenic symptoms. Well, hallucinations, which are perceptual experiences that occur in the absence of external stimulation. Auditory hallucinations are much, much more common than visual ones. In fact, it's unusual to see visual hallucinations. Auditory hallucinations are characterized by hearing voices, someone telling you to do things. Okay. Also associated with that are delusions, which are beliefs that are contrary to reality. We have as subcategories of delusions paranoid delusions, which are beliefs that other people or agencies are plotting to harm them. Grandiose delusions are beliefs that one holds special power, unique knowledge, or is extremely important. Then we have somatic delusions, belief that something highly abnormal is happening to one's body. For brevity, I'm going to leave the rest of the schizophrenia symptoms up to you. It is adequately covered in the OpenStax college textbook. It kind of describes disorganized thinking, disorganized or abnormal motor behavior, and in particular negative symptoms, which that we have to distinguish from positive symptoms. Negative symptoms doesn't mean the absence of symptoms. It's simply negative symptoms refer to decreases and absences in certain behaviors, emotions, and drive. Some avolition, lack of motivation, elogia, reduced speech, asociality, social withdrawal, and anhedonia, an inability to experience pleasure. These are some negative symptoms. All right, everyone. I'm at about time 51 minutes, and so I am going to stop at this point. But I just want to remind you to continue reading the rest of this chapter as it describes more psychological disorders, disorders of childhood, and so forth. And I do have a number of questions on the exam with regard to that. So please continue reading, and look for my next video presentation, which is going to cover therapy. All right, so keep up the good work, guys, and stay well and be well, and later.